Simple Stuff Works. Join us. I'll pass you over to Anna in a second, but just for those, I don't like to say late attendees, just to let you know a little bit of housekeeping, please keep your camera switched off, keep your mic switched off. If you have a technical issue, perhaps the speakers not working, there's a vision problem, or the signal is buffering, what we find works best is just to leave and rejoin the meeting. While we're on the subject of messaging, we can use the chat feature as well if you've got a technical problem. My colleague Kim is working in the background to monitor the presentation. Also, if you have a query with regard to content of the presentation, use the chat feature to post a question. We'll come back at the end and we will endeavour to answer your questions. After we finish, we'll send you a copy of the presentation, plus a link to the recording of the presentation so you can share that with colleagues as well. So I'm just going to pass you over to Anna, and I'll leave Anna introduce herself. And she's just going to share the screen with you now, and I shall see you in about half an hour, 40 minutes. Thank you.
Thank you so much, Les. Hi, everybody. It is fantastic to see so many of you here today. I'm just going to share my screen. So just give me 1 second and I'll make sure everything's okay. We have just tested this, so hopefully it'll be fine. So if I share that, and then here we go. Hopefully everyone can see this okay. Kim or Les, if you shout out at me if you can't see this, that would be great. Right then. So yes, 24-hour postural care. So we all know there are incredible seating solutions kind of out there, and you know, a seating solution can work absolute wonders for people's quality of life, for people to access a community and things like that. But we also need to be thinking about supporting people at other parts of the day as well, and that's where kind of we come in. So my name is Anna, and I'm one of the directors here at an organisation called Simple Works. I'll explain a little bit about kind of who I am, so that we can kind of work out sort of why I'm talking to you today. So we focus on understanding the lying posture. Okay, so the lying posture is an area of sort of therapeutic intervention that, I'll be honest with you, it's quite hit and miss across the country and across the world. Really, some places are absolutely kind of, you know, getting the lying posture spot on, which is fantastic. Other places are still kind of learning about it and kind of coming to an understanding as to kind of why it's so important. So what we're going to do today is we're here to kind of get a bit of a grip about kind of what postural care is over the 24-hour period. So what is protection of body shape in particular? And we're going to think through how the lying posture and our seating can work together and provide the best sort of postural care for the children and the adults that we are supporting. I'm going to think through some examples of best practice. Now, because I'm sharing my screen, I can't see the chat box. I can't see yourselves. I've just got my presentation in front of me. So like Les says, if you can just pop your questions in the chat box and we will tackle all of that at the end, basically. Okay, so who am I? Let's make it all about me for a minute, guys. Okay, so my name is Anna, like I've said before, and I am one of 3 directors of an organisation called Simple Stuff Works. So I started Simple Stuff Works back in the early 2000s. So I've been doing this for a very, very long time. Myself and my sister Sarah actually head up the organisation, and there's just some photographs of us as small children. And we are continuing the work of our parents, who are John and Liz Goldsmith. Those of you who kind of maybe work as in sort of physio and things like that, you may or may not have heard of the Goldsmiths. Mum is a physio, Dad was a weapons and explosives specialist in the British Army, and together they're kind of cited as sort of pioneers, really, of therapeutic positioning. So my mum worked in a big institution here in the Midlands called St Margaret's. It was a huge institution for people with complex disability. It had a children's ward all the way through to kind of elderly care. And Dad would pick mum up from work and say kind of like, you know, how come when I pick you up, like everyone's in bed, or people are lying on bean bags, or people are lying on the floor? And mum explained to him this idea that kind of when your body shape starts to change, you can't sit in conventional seating, which is, you know, a bit of a challenge. So my dad, being the kind of guy that he is, sort of back in the 1980s, he went off and designed some of the world's first multi-adjustable seating solutions. So anyone who's kind of old enough here to know about the kind of the spa chairs and things like that, they were the brainchild of my dad. He then kind of like together, they then went on to kind of think through, you know, while seating is one of the most incredibly powerful tools that we have available to us to support people, Dad was like, I think we're missing something here, because if you look at how people are lying down, there seems to be a pattern. There seems to be a bit of a pattern happening. So he was having a look and he was saying, if you see, regardless of diagnosis and regardless of age, you can see how people are lying in the same sort of postures. And there's got to be something in that. So he went off to the biomechanics department at the University of Birmingham, and he said, right, I've got this idea, I've got this theory. And he went on to write sort of some of the world's leading research into what we call the biomechanics of body shape distortion. Sarah and I kind of sort of, we've grown up around this. We spent our childhood childhoods at NADEX and at exhibitions and things like that. And it's kind of what we've done our whole lives, really. So we went on to write some accredited training courses looking at the biomechanical theory and how we can apply theory to practice and things like that. And we're known now, Sarah and I, kind of globally for supporting teams to develop their services around therapeutic positioning and postural care services. So we've got like a very strong pedigree in this. We have been doing this forever and ever, and we are renowned for being the people that you come to if you need support with the lying posture. Yes, that's kind of where I've kind of come from today. So hopefully you all feel like you're in safe hands when we're thinking through understanding therapeutic positioning. Okay, so we're going to make a start. There are some really basic principles that we need to get our heads around here. So we have around 8,760 hours a year available to us. And someone with a movement difficulty, say if they're a child, they'll spend 1,140 hours in school, a bit longer if that person maybe goes to work. 7,620 hours with your family, friends, people that support you. But generally people spend around about 3,640 hours in bed. So immediately you can see people are spending 3 times longer in bed than they are doing anything else. So if we don't get that kind of that lying posture right, automatically we should all be kind of coming to the conclusion here that we've got some issues, haven't we? You know, gravity isn't on our side at this particular time, and nor is time. Okay, so we need to think through, how do we make sure that the lying posture is sorted? If we get that right, then we're going to make a massive difference to things that happen in the day. And the lying posture really does seem to be the missing link for a lot of people. So you will be working with people, I'm sure, that are very complex. You know, it's kind of why you're involved in their care. And you might be finding that you've got some really, really challenging situations when it comes to seating, for instance. But I can guarantee you that your problems in seating that you're seeing, they'll have their root cause in the lying posture. And so we need to take kind of the lying posture as a real priority, because the lying posture, for absolutely every single one of us, the lying posture is the blueprint for everything. The lying posture will become the way someone sits. And then obviously the way that someone sits will dictate what happens in the day. It will dictate what they can do, where they can go, the kind of pain they might be experiencing, the extent to which they can generally get on and participate and enjoy their life. But it starts with the lying posture. Okay, so why is the lying posture so important, and why is it so important to think about, particularly for people with movement difficulties? So the lying posture shouldn't be an issue for people, really, in the sense that, like, when I go and lie down, the lying posture doesn't cause me any difficulties because of one key fact. I have the ability to fully straighten my hips and my knees. So that means that when I go and lie down, I can lie down in whatever position I want to, because I can make full contact with the bed when I lie down. But if I can't fully straighten my hips and my knees, I'm going to struggle to get comfortable, because there's going to be a bit of a gap when I lie down. So there's nothing good about body shape distortion, as you'll go on to see. But the one good thing about it is predictable. And once you've seen one pattern of distortion, you'll start to realize you'll see it over and over and over again. So obviously, if we're looking at patterns of distortion, if we're looking at predictable patterns of distortion, that gives us potential to do something about it. So what you'll start to see is an individual with a movement difficulty. When they lie down, they'll adopt one of three positions or an iteration of one of these three postures. Some people bring the knees together. Some people, particularly if they have quite low tone, their knees tend to fall out to the side in a sort of frogged posture. Or very typically, people will wind sweep, which is where both legs fall to one side, okay, and the pelvis will drop back in the opposite direction. So these destructive positions, I am certain that you will have seen time and time and time again. So regardless of age, regardless of diagnosis, these destructive positions are the same the world over. They tend to be asymmetric. They tend to be unsupportive, and we're going to go on a bit later on to talk about this concept of positioning for sensory feedback. An unsupportive position doesn't give people enough proprioceptive feedback in order to relax. So you'll see increases in muscle tone. And these positions also give you an increased risk of pressure injury as well. Now, people will say to us, what's the big deal? So someone, lies down in a destructive posture. We all lie down in destructive postures. What's the problem? The issue being is that if someone lies in a destructive position and they find it challenging to move out of that position, and over time, the habit of getting into that particular position becomes obligation to them, their body shape will start to change in ways that can be incredibly challenging. The confidential inquiry into premature death for people with learning disabilities, KIPOLD, and I will send through the links to Kim and everyone to send out to you after this. KIPOLD has cited body shape distortion as a cause of premature death. And I'm going to show you now a series of x-rays, which, whilst they're not pleasant to look at, it's really important that you understand what you're up against when we're thinking through body shape distortion. This goes far beyond positioning for comfort. Comfort is a priority, but this goes far beyond just trying to keep people comfortable. This is about protecting the longevity of people's lives as well as the quality of life. So what you've got here is Fred age 3. So there's a gentleman here that we're going to see over a number of years. So Fred age 3, his chest is looking pretty good with regards to sort of chest shape. The image on the right of your screen here is just to show you kind of where your internal organs should be. And that will become clear in a second as we move through this presentation. So Fred age 3. Fred age 10, can you see here? He just has a very slight curve, just starting to pull around to his left. It's really subtle at this particular point. And if we were measuring body symmetry using the Goldsmith indices, which we're going to talk about later, this is a really fundamental kind of outcome measure that people can use. But if we've been measuring body symmetry at this point, we'd have picked up on this asymmetry and something could have been done about it there and then. Unfortunately for Fred, that's not available at the time. So you see Fred here at age 10, the intervening years, Fred age 17, you can see here kind of how things have progressed and really kind of, they've got really, really complicated for Fred here. So his spine has continued to distort. His ribs and his hips have made contact at this point as well, which is indicative of two different types of distortion happening. You'll have compression distortion and rotation distortion happening in his chest. We're going to talk about both these things though, so don't worry. The contents of his abdomen here has been pushed up into the space reserved for his lungs. So this right lung is no longer functioning. Now, again, thinking through KIPOLD, the confidential inquiry, respiratory failure is the biggest killer of people with complex needs here in the UK. So when you consider when people's body shapes start to change, it's no wonder people run into respiratory difficulty with distorted body shape. So Fred age 17 there you can see he's really struggling. Fred age 21, Fred age 23. Now Fred died very soon after that x-ray was taken, which I don't think would surprise any of you because his body shape simply isn't compatible with living at this particular point. So when we're thinking through body shape distortion and protection of body shape and postural care, this is what we are trying to protect people from. Body shape distortion is not an inevitable part of having a disability. And if we can utilize the lying posture along with incredible seating solutions, then you're going to make a massive impact on people's quality of life. Most people start off symmetrical. So first of all, we have a duty of care to protect people from these avoidable secondary complications. But really excitingly, we can also restore body shape using the correct therapeutic intervention in the lying posture alongside brilliant seating solutions. So whilst that's the grim bit of the presentation done, out of the way, that's we know what we're up against now. This is about moving forward in a really positive way. So body shape distortion is grim. Body shape distortion happens slowly, right underneath your nose. It's been labelled the carbon monoxide of disability, which I think is a really brilliant way to put it. But really excitingly, we can do something about this. Okay, so effective positioning, really simple. Okay, it's going to be more symmetrical. It's going to be more supportive. So we're going to think about sensory informed positioning, which we'll talk about a little bit later on. And we're going to decrease our pressure injury risk in these sorts of postures because we're going to spread the weight of the person over a much bigger surface area. Now, I can guarantee you though, at least one of you in this group would have thought, well, I couldn't sleep like that. And I can guarantee you that a number of you will have had conversations with families and care teams that say, I don't like the look of that, it looks a bit weird, it looks a bit restrictive. Oh no, I wouldn't want to be sort of held in that position all night long. These are really common conversations that we have about therapeutic positioning with people every single day. And they're understandable, okay? So therapeutic positioning can look a little bit odd. If you're not familiar with it, the idea of kind of supporting someone in the lying posture like this, it can look a little bit odd. But we have to help people to understand that people with movement difficulties are often limited in the number of positions they can sleep in anyway. Because of this limitation in their body shape with the hip and knee flexion, their choices are limited on what position they can get into. So we need to support people to get into good positions rather than the destructive ones. And we have to also help people to understand about this idea of restraint and this idea of kind of holding people in one position. So we come back to the car seat analogy. So when my children were little, they went in car seats. You know, they don't let you leave the hospital, do they? Unless you've got your baby in a car seat, because we've all seen those crash test dummies that show you brutally why it's so important to use a car seat. It is culturally not acceptable to have children not in car seats. You'll have all been on the motorway and you've seen a child roaming about the back of someone's car and you feel furious about it. So we have to help our families, our care teams, carers, individuals themselves. We have to make people aware kind of what are the risks associated with leaving someone to experience body shape distortion. What are the risks associated with leaving that person? And what benefits can we achieve by using equipment that could look at being described as restrictive? And only then can people make balanced judgments as to whether or not they want to have a go with this. I have never met a family in the 20 odd years I've been doing this now. I've never met a family who say, I'd rather take my chances with body shape distortion, thanks. I have met a family who have said, do you know what, like we're moving house and it's not the right time for us to look at this because it does take quite a lot of support to kind of get this right in the early days. Or I've met someone who says, we were doing really well with it and then she went into hospital and we've had to start again. You know, it's not easy to do, but I have never met a family who says they'd rather have a go at body shape distortion. So we need to make sure that our families and our care teams have got the right information first of all, before they start making decisions about whether or not they want to use therapeutic positioning. Okay, so a little bit of biomechanics here. So why is it that my body shape hasn't changed, but someone with the movement difficulties has? You know, what's happening in the body, and why is it that this is something which is common across all sorts of ages and diagnoses? You know, there's something happening at the body, isn't there, that we need to be aware of. So when we're lying down, this is ideally what we're after. This is the body in balance. So your pelvis will be level. Okay, so the pelvis there will be level. And this line here is an imaginary line running from the sternum to the spine. And we want that to be vertical. That's the sternospinal line. And we're going to keep coming back to the sternospinal line. If the sternospinal line falls at an angle, we start to run into difficulties because the chest wall mass here is really flexible and wobbly. Okay. The area all around your sternum is cartilage, so it's very flexible structure. And without support around this, it's really vulnerable to distorting. And in fact, every single one of us, when we go and lie down later on and get into certain positions, if you're lying on the sofa or you get into bed, your chest will change shape because it can, and it happens to all of us, and it's normal. But normal distortion, you can see here with Abigail, the little leg turn, little head turn, her chest is rotating there towards her right-hand side. So her sternum's moving over here and her chest is coming over this way. You can see here in this gentleman, the same sort of position, because over time he's not been able to move out of that posture. You can see there how that normal distortion has become really exaggerated for the gentleman on the right of your screen there. We also need to help people to understand the impact of a position over a long period of time and the reasons why people get into certain positions. Because how many of you supported a family where they say, but she really likes to sleep on her side, or she really likes to sleep on her tummy? And again, these are really, I like to sleep on my tummy. That's how I sleep. But we have to help people to understand that what can begin as a really comfortable, secure position for someone over time is going to cause them problems if we don't kind of keep a check on it. So this young man here is called James. James is 9 in the first picture and he's 19 in the second picture. So at age 19, James has got that very significant head turn here, which is causing his ability to swallow safely is getting really compromised. He's got this long asymmetric lordosis, right? Which means that trying to get him comfortable in conventional seating is nearly impossible. And the progressive flexion and contractures at his hips and his knees mean that he's down for tendon lengthening surgery. So they're thinking potentially he needs a peg because he can't swallow safely. His seating, they now need to think about kind of really expensive, complex, custom contoured molded stuff. And he's looking at surgical intervention as well. And actually, every single one of those complications you could have predicted from this first picture. So we have to kind of start thinking through positioning and start thinking through kind of forward planning as to kind of what's going to be the long-term impact of someone's position, and how do we help to support them to make sure that position isn't going to impact them in the long term. Okay, now, as we're thinking through changes in body shape, those of you who are specialists in seating, we need to kind of think about some seating principles. And to be quite frank, when we're thinking about the lying posture, you need to throw some of those seating principles out of the window, because we're going to look at the body slightly differently in lying than we do in seating. You can always tell when a seating specialist is at a bash at nighttime positioning. So what we can see here, when this person comes to kind of get on with their day and like kind of sits upright, you'll probably see some lateral flexion as the person falls down to this side over towards their left-hand side. But in the lying posture, what we've got here, it's not lateral flexion, it's a rotational distortion in the chest. Okay, so this is when the sternospinal line that we talked about earlier falls towards the person's left-hand side. Now, because we know that the chest wall mass is a really wobbly, kind of vulnerable tower, the minute that that sternospinal line collapses to the left, the whole chest wall mass collapses down towards the supporting surface. You'll see a little rib flare here, and you'll see a rib flare along the person's back here along the right-hand side as well, usually. Okay, so this is what this looks like, rotational distortion. Now, if everything going over to the left here is clockwise rotation, that's what's happening on the inside there. You can see the spine kind of being pushed around, then forced up into the space reserved for the lungs over here. Everything going to the left is clockwise rotation. Everything going to the right is anti-clockwise rotation. So again, you can see how this person's chest is collapsing towards the right-hand side in a rotational configuration here. Now, why is it important to understand about rotation? So we need to know about rotation because we're going to utilize therapeutic positioning in the lying posture to do something about it. Now, you can pick up rotational distortion really early on before you can see it by using measurement. Now, we haven't got enough time to go into measurement today, but if anyone wants to know a bit more about how you can take these objective validated measures of body shape, do let me know. But the Goldsmith indices will take critical chest dimensions, and it will help you to understand what's kind of going on at someone's chest, and you'll pick up changes before you can see them. So that's really exciting, because you can do something about these quite catastrophic changes in body shape. You can do something about them kind of, before they get sort of a grip of somebody. So if someone's rotating, whether that's in a clockwise direction or an anti-clockwise direction, we're going to utilize our therapeutic positioning to do something about that. So we're going to de-rotate the chest, which sounds like you're going to do something awful to somebody, which I promise you're not. It's a very, very gentle, supportive strategy. So this young man is rotating in a clockwise direction. Okay, he's just starting to head over towards his left. So his sternum is moving. So his sternum's about here. It's moving towards his left-hand side. He's got a little rib flare down here, but it's quite subtle at this particular point. And what I've seen time and time again is people will put a lateral here and a lateral here and think that they've nailed it, think that he's fixed. And it's just not going to work, okay? Because it's a rotational force going through his body, not a lateral one. So what we need to do is, whilst he's lying down, we block in the right-hand side, and then we gently roll him towards the right to get his sternum back in the middle. Okay, so sternum central. That's a little mantra that you can tell yourself when you're thinking about this, sternum central. So you can see here in this third picture that derotational force has been applied to get his sternum back into the middle here. And we've made that rib flare look really prominent. And that's okay. That's normal, okay? Because that rib flare was there all along. It was just down here. We've made it look more prominent by applying this particular force. But if we keep doing this night after night after night, hours after hour after hour that you can when someone's lying down, you will make phenomenal changes to postural molding. So you can see here this young man who's 25, you can see the difference here in 3 months. So he was rotating in an anti-clockwise direction. Then we've utilized his positioning strategy to de-rotate him. And you can see his chest here on the right of the screen. It's much wider, it's more symmetrical, his oxygen saturation's improving, chest infections decreasing, which is all brilliant. The issue here for this young man is he no longer fits his custom contoured mold. So when we're thinking through your seating and your nighttime positioning kind of strategies, they've got to work together. There's some incredible seating solutions out there that will support you to adapt to someone's body shape changes. Some of the CareFlex stuff is just fantastic at this. But you've got to make sure that your seating and your nighttime positioning are working together. Otherwise, one will undo the other, which obviously is not what we're after for people. So you can see there the impact, though, of 3 months of applying a therapeutic positioning kind of force for this particular young man. Okay, so when we're thinking through some actual positions, I want you to keep coming back to the idea of your seating. Okay, that's what we're here to talk about today, is understand the impact of the lying posture on seating. Now, side lying is going to cause you some problems with your seating. Okay, it's going to cause problems with body shape, and it's going to be a challenging position for the body to tolerate for long periods of time. So sometimes people will say to us, it's okay, we practice symmetrical side lying, which is practically impossible. That's the closest you'll get to symmetrical side lying, but most people don't tolerate that for very long because of the weight in the bottom shoulder. So you can see here, Thomas has swung the bottom shoulder backwards, and here he's swung it forwards. Okay, so you get lots and lots of rotation immediately going through the chest. In side lying, you're going to really struggle to control your contractures as well. And you will not be able to control scoliosis in side lying because gravity is simply not on your side. However, for some people, side lying is your only safe option. Okay, so what we need to think through there then is how do we limit the damage of side lying whilst making sure that person is safe? Some people are at risk of aspiration, vomiting, choking, and so therefore you'll have to use side lying to keep them safe. So how do we limit the damage of side lying? Because these sorts of postures are incredibly challenging for the body. If you think about pelvic obliquity in seating, there you go, it's probably coming from here. That's just one of those things that always gets me when you think about, whenever we talk to anyone about obliquity, you ask them how they lie down, and usually it's in this sort of position. So side lying and its impact on not only body shape but also kind of your seated posture as well. It's a really challenging position to for the body to tolerate. Same as prone. So again, this young man here, you can see he's lying on his tummy. He's windsucked his legs to his right. He's got that typical arm posture there of someone who sleeps on their tummy, head turn, and that really strong asymmetric lordosis look can you see when you bring him up into his seating. Now for this young man, his seating is really challenging. He can't get comfortable. But when you feel his stomach, you can also feel his spine through his stomach at this point because everything's just crashed forwards. So again, your prone lying is going to cause you kind of complications, with body shape. Once you know what you're looking for when it comes to therapeutic positioning, you'll be able to spot your prone liers from a mile off because they'll have a very typical arm posture and a head turn, strong anterior tilt on the pelvis, and that strong lordosis. I can guarantee you, okay, they are people who sleep on their tummy. So side lying is a challenge, but sometimes you might have to use it for people for safety reasons. Prone lying is one of those things where it's great for some sort of short-term stuff. So for chest physio, for for getting people onto like wedges to get their arms down into the middle and things like that. It's great for active physio and things like that, but prone lying for long periods of time is going to cause the body some challenges. So when you're thinking through positions and seating, side lying and prone lying are challenging, which brings us to the lemon meringue pie principle, which I know sounds incredibly twee. It sounds a bit kind of silly, and I suppose it's meant to. The point being is that we support really complex children and adults. Okay, they are medically fragile. They have a lot of medical needs going on. That doesn't mean to say, though, that every single solution for them needs to be incredibly complicated. It's really obvious when you think about it. If you put a lemon meringue pie in the fridge upside down, it won't look like one in the morning. If you put one in the fridge on its side, it won't look like one in the morning. The body's the same. Okay, you need all the heavy stuff on the bottom. You need the scapula, the spine, the pelvis. All of the heavy stuff needs to be underneath in order to protect the soft, fluffy stuff on the top. Okay, it's as simple as that. It is a common sense principle. If we leave the body in a heap, kind of with the spine on the top and things like that, someone's going to run into predictable difficulties. But the lemon meringue pie principle is a really lovely tool that you can use to help people to understand, look, we need heavy on the bottom to look after the soft, fluffy stuff on the top. And the body is exactly the same. Okay, the body is just a slightly more highly engineered lemon meringue pie. So supported supine lying is your friend. Now, you can profile the bed, you can elevate the head, you can play around with the position, but generally getting people into these supported supine positions is what you need to do in order to protect their body shape. Now, not only is supine lying absolutely brilliant for protection of body shape and for protecting the internal organs and the skeletal system and things like that, what's really exciting is we're also learning now about how supported supine lying has a massive impact on sensory feedback and tone as well. So in Belgium, there is an incredible therapist called Jo de Klerk. Now, I know I spotted a couple of names in the waiting room earlier, people who I've had the pleasure of working with already and who I know already know Jo. But for those of you who haven't heard of Jo de Klerk, I would highly recommend that you please take a listen to some of his work. So Jo is a physio from Belgium, and he uses positioning not only to protect body shape, but also to provide sensory feedback. And he's been doing this based on his understanding of the parietal lobe. So the parietal lobe, this blue section here of the brain, I've been assured it's not blue in real life, but the blue section of the brain here is where the somatosensory cortex lives. And it's what processes proprioception and allows the body to orientate itself in space. So right now, the parietal lobe, like all of your parietal lobes, are taking feedback probably from the chairs that you're sitting on. So from the back of your thighs, from your bottom, from the back of the seat against your back, probably from the soles of your feet, which are kind of resting on the floor. And what the parietal lobe does is it processes all of that information, that physical contact with the back, and it allows the body to kind of balance and to know where it is in space. The individuals that you are supporting, those of you in particular who work with individuals who have dementia or neurological damage, you may find the parietal lobe is really struggling and people don't quite know where they are in space, which results in very tight fetal positioning It results in high tone. It results in people kind of clinging onto the bed rails because they don't quite know where they are in space and things like that. So if we can position people and turn the volume up for them on where they are in space, that helps you to manage tone. It also helps you to manage pressure care because you're going to spread the weight of the body over a much, much bigger surface area. So Jo's work over in Belgium, he works in a large care home over there for individuals with a diagnosis of dementia. And the individuals that they support are not turned throughout the day, okay? They're turned once a day, usually as part of their washing and dressing process. It's called one-turn care. And I know that there'll be people listening to me talking now who are already having kittens thinking, well, surely, you know, what about pressure? What about pressure? We have to turn people all the time. Jo's finding that's not the case. In the last 6 years, they haven't had one incidence of a pressure injury because they use sensory informed positioning to spread the weight of the person over a bigger surface area to allow the person to relax and to protect their body shape. So it used to always be that like you couldn't use a positioning system because what about pressure care and the person's on a particular, you know, jazzy pressure mattress? The two go hand in hand. If you get someone's postural care right, you will improve their pressure care, which is just a brilliant win-win-win, isn't it, for absolutely everyone? So supported supine lying turns the volume up on the parietal lobe, helps the body to orientate itself in space, allows the body to relax, and protects body shape as well. So it's just an absolutely fabulous thing to do for people. Now, I've just got a couple of photographs here. So James is the gentleman on the left of your screen here. Leslie's going to talk a little bit more about James in a little bit. So James is a gentleman that Careflex have supported with his seating. And Tommy, the gentleman on the other side of the screen here, Tommy's a gentleman that we have supported in Australia. Now, I've popped them both on the screen here because I want you both to see kind of how, can you see how similar their body shapes are? Okay, so Tommy is James, probably about 5 to 10 years, a bit further down the line perhaps. But Tommy's got very complex body shape, as does James. Now, Tommy we were supporting from a therapeutic positioning point of view because he wasn't tolerating his seating. He was really struggling with his seating. He was really upset whenever he was in it. He would make himself sick. He would scream. He would cry. He was really struggling with his quality of life. So we were supporting Tommy to understand kind of how we can use his lying posture to make positive changes to his seating. So Tommy here, you can see this is how Tommy sits. That's how Tommy used to lie. So can you think about, remember the start, we were talking through how your lying posture is just your seated posture. The way you lie becomes the way you sit. And you can see this perfectly with Tommy here. So over 2 years, very gradual derotational support for Tommy in the lying posture. You can see this phenomenal impact on his seating. So Tommy's 40 in this picture and he's 42 in this picture. So the only intervention here has been therapeutic positioning and that derotational force in particular. That's the key thing, is that there's a big difference between just positioning someone and therapeutically positioning someone. My fabulous colleague Laura from Canada put it perfectly to me the other day, and she said, well, if you just lie someone down, you've positioned them. That's it, isn't it? But if you apply the right forces and you apply the right supports, then you're therapeutically positioning them. And it was like, absolutely, that's exactly it. So 40 here to 42, but can you see the impact on his seating has just been absolutely phenomenal. So Leslie's going to talk a little bit more about James, but I just wanted to kind of share with you those pictures there, just to kind of show you that destructive positions and body shape distortion is the same the world over. You know, hip and knee flexion is hip and knee flexion. Doesn't matter where you live, where you're from, what diagnosis you've got. And body shape distortion occurs exactly the same way for anyone who's at risk of it. So when it comes to understanding therapeutic positioning, there's lots of things that as a service and as service providers, you need to be thinking through. Now, for service providers, outputs are great. You need to know how many times you're seeing people. You need to know how long has that person been on your caseload. Do you need to discharge them? Are you getting the right equipment in place for them? Are you getting that equipment in on budget? That's all important stuff, and I'm not here to say it's not. But from a postural care service point of view, you need to be thinking about outcomes, not outputs. So outcomes are very different. Measurement to body symmetry. Now, NHS England has cited using validated objective measures of body symmetry as best practice for postural care services. If you want to protect someone's body shape, measure their body shape. And if you want to see kind of like, you know, really competent and confident families, then we need to think about our training needs, don't we? At one point we worked out there was about 47 people involved in Tommy's care, you know, which is a huge amount of people that needed to be trained. Everyone needs to know what the derotational forces were all about. Everyone had to know what the goals were for him. But you know, if you've got really competent, confident families, care homes, care teams, you know that your postural care service is working. Wakefield, for instance, who is their paediatric therapy team, they saw the numbers of children who accessed their service who experienced hip dislocations reduced to 0 when they implemented a fantastic postural care service, like 0 hip dislocations. That's unheard of. You'll see reductions in pain and distress, you'll see reductions in surgical interventions, and you'll see reductions in secondary complications. Therapeutic positioning in the lying posture for so many people is the missing link. It is the piece that we need to get in place, because you've got some unbelievable seating solutions out there for people, you know, which are fantastic. But if we don't get the lying posture right, your seating solutions are going to have to get more and more complex to support really complex body shapes. But it gets to the point where you can't even use your brilliant seating solutions because someone's body shape has deteriorated so badly. So we need to help people to understand the impact of the lying posture, and keep coming back to this idea. The lying posture is the blueprint, and it is the key to preventing secondary complications that we now know to be avoidable. Body shape distortion is not an inevitable part of having a disability or having a neurological impairment. Body shape distortion is preventable, and when we know what we're up against and we know how we can fix it, then we really need to be kind of cracking on and making sure we don't expose people to these avoidable risks. So I'm going to just leave my, there's my contact details there. I will pop them in the chat box as well. But I just want to say a huge thank you to you all for listening to that, and for bearing with me with the old presentation. No one, you know, I don't want it to be like death by PowerPoint, so I'm going to stop talking now. And I'm going to hand you back over to Les, who's going to take you through your seating solutions and the options that are available to you from CareFlex. Thank you all so much, and I'm just going to attempt to stop sharing my screen now. Thank you.
That's great, Anna. Thank you for that. I think we'd all agree that's a very thought-provoking and engaging presentation. Plenty of food for thought. What we're going to do now, though, is we're going to have a look at the role of specialist seating in a 24-hour postural management programme. And for that, we're going to use the case study. We met James briefly in Anna's presentation, and we're going to have a little look to see how we helped add input into James's postural care. So if I can ask Kim just to share the image of James, please. We're just going to share screens in a second. Thank you, Kim. So this is James, 49-year-old gentleman with cerebral palsy, epilepsy and severe learning disabilities. He's in need of full assistance for all areas of daily living. Fully hoisted, has difficulties with swallowing. Postural challenges are listed on the next screen, but we'll run through those in a little while. If you just click on the next, that's okay. That's it, Kim. Sorry, I got a little bit of buffering on my screen here. So if you want to go back, that'll do. So we're looking at, he had poor postural control, pelvic instability, scoliosis, hypertonicity with contractures, wind-sweeping deformity, fatigue and swallowing difficulties. So James's solution, his seating system, would need to manage both health and well-being, protecting his body shape, reducing fatigue, promote safe eating and drinking, and really importantly for James, he's quite a relatively active individual. We needed to make sure we can get the chair through from room to room. So if you can just switch the live camera on, Kim. I'm just going to work on a chair just to explain what we did for James. So the seat we looked at for James in particular was the SmartSeat Pro 2. Now, I'm not going to turn this into a product presentation. If you need to know more detail on the chair, feel free to post a question in the Q&A, or you can refer to the website where you'll get a full overview of what the chair does, little how-to videos and how we adjust and operate the chair as well. So first consideration for us was flexibility, because James is relatively complex and the chair needed to be fully adjustable for James. So with the SmartSeat Pro, we can adjust the seat width and the seat depth, helping to provide James with a solid base to help with his pelvic stability, to provide a solid base for James to work from. We also added a 4-point pelvic strap, partly to help with pelvic stability, partly to address this issue that we had with James as well, where he was sliding forward in his chair. The solution or the cause of that sliding forward is a little bit more complex, and we'll have a little look at that as we move through the presentation. Tilt in space, again, ideal for pelvic stability. The back to seat angle remains constant, so great for fatigue management as well. But if you remember, when we looked at some of the challenges James was facing, one was difficulty with swallowing. So tilt in space needed to be used with consideration. To help with this, on the chair we have an inclinometer, or a tilt in space gauge is the easier way to think of that. So it means we can actually measure the amount of tilt in space we use with a chair. So for James that was critical. So for example, perhaps, you know, after lunch or during lunch he was upright. After lunch we didn't want to go back further than 10 degrees because that would cause us issues, or cause James issues with his swallowing. After lunch or after a couple of hours we could increase the tilt in space perhaps to 20 or 25 degrees, but we could measure that, and that information could be placed in the care plan. Looking at back angle recline, we used back angle recline to help accommodate the fixed contractures that James had at his hip. James couldn't physically sit at 90 degrees, so we needed to open up the back angle to accommodate that fixed posture. We need to be very careful when we open up the back angle because it can promote somebody slipping forward in a chair. And James in his old chair did have an issue with slipping forward as well. The back is multi-adjustable, so this would help accommodate and prevent further decline with the scoliosis. Each section can be adjusted, moved up and down, rotated, angled. We can open up the wings. It's a really adjustable seating system, and it was ideal for James. The other thing that James had an issue with was wind sweeping. It wasn't as fixed as we first thought it was, but what helped was, you know, wind sweeping is happening above the hips and below. We could accommodate by just angling the back sections out. We also used a pommel to help with leg alignment, to keep James in that nice midline position, and angle the pommel as well. So that was ideal for James. Channel leg rest. James didn't really need a channel leg rest, but what was evident was that there was an issue with the way that the leg rest was being used on his current chair. And we've picked up this kind of issue. If we'll have a look at the pictures in a little while, we'll show a picture of before and after. Basically what was happening was that James had limited, he had contractures at the knee. 90 degrees was his limit at his knee, at the knee. And what they were doing, or carers were doing, was raising the leg rest. So in effect, trying to open up that angle. Now James couldn't sit at that angle. The only way that he could sit at that angle was to bring his pelvis forward to create that 90 degrees at the knee. Hope that makes sense to people. So a big part of the vision of the chair was the handover process, where we really explained to carers about how the leg rest would work and what its limitations were and how it could adversely affect James's posture if it was elevated too high. Just checking my list to make sure I've covered everything. Hypertonicity as well was helped with a good seat width and a good seat depth, providing that pelvic stability. So, Kim, if you can just load the second slide, the before and after, and we'll have a look at James. Second slide, Kim. There, you can see the before and after. You can see James is in a much better position, fully supported, helping with his pressure care, helping to spread the pressure over a greater area. Coming back to the leg rest, if you look at the leg rest in the first chair, the black chair, you can see it's extended, it's elevated, and what that was doing was dragging James forward in the chair because he couldn't sit at the angle that the leg rest was trying to make him sit in. Next slide, Kim. So this was the potential solution for James. So I've mentioned tilt in space, helping to manage fatigue and pelvic stability. Back angle recline helping to accommodate James's fixed contracture at the hip. The multi-adjustable back helping to accommodate and correct his wind sweeping posture. The pommel was used again to help with adduction and wind sweeping. Thank you, Kim, just trying to catch me out there. And the angle adjustable foot plate giving him great support at the feet. He was quite strong. He could push down really heavily through the foot plate, so that it was giving him great feedback. As you can see, his feet are well supported there. And that's James. It was a pleasure to meet James. And I think that covers us for now. Kim, if you want to come back to the screen, and perhaps Anna or myself will take some Q&A questions and try to answer. Do you have any questions for us, Kim?
I think Anna's done a great job of going through
background
in the chat.
I've just done a couple. I've just sent some links through for so lots of people asking about measurements of body symmetry. So I sent through information there for you all, so you can kind of make a start on that. There's also lots of videos on our YouTube channel, which again, I'll send everything through to Kim so that you've got like a list of things that you can be kind of going on with. Someone asked just regarding about having kind of reps that will come and support you. So the way that we work is so we're entirely online. So the way that we will support you is regards to assessments and things like that is we will always have availability the next working day to see you. We often run kind of online clinics and things like that. We will take a look at people and see what sort of positioning strategies you could implement. And we can also get to see you kind of in person to take you through some equipment and to skill you up with regards to kind of where to start from an assessment kind of point of view and things like that. We've worked kind of all over the world like this now. So we have clients in Australia, as you saw with wonderful Tommy there, and yeah, kind of this is we're very good at supporting people to understand the lying posture. So do just get in touch with us and we can kind of get you booked in. Or there's a question about seating, which means that I'm going to sit back because I haven't got a clue. Les, that's yours.
The sit back, pardon the pun.
Can you remind me why adjusting the back angle can make someone slip forward in the chair? Is this when someone can't sit at 90 degrees and the back angle recline is put to upright?
Oh, yeah, possibly so. So what we're looking at is somebody who can't achieve 90 degrees at the hip, or we say 90 degrees, it's not exactly 90 degrees, but can't achieve that 90 degree. So if they sit slightly in a more open posture, you just open the hip angle. What we've got to be careful of is that we don't put the pelvis into a posterior tilt, and it'll help to allow them to slide down the chair. We also use a 4-point pelvic strap to help lock that person's pelvis in that neutral position as well. What tends to happen is that, part of the setup or part of the assessment process, we work very closely with a healthcare professional. We'll have evaluated the full range of movement at the hip. Hopefully, sometimes that happens. If not, we can work it out as part of the assessment. So we'd open up the hip angle, set the hip angle, the lever here locks, and just use tilt in space. So it's a tilt in space chair where we've adjusted the back angle recline. They're totally separate movements in the chair. That makes sense?
Hope so. I think so. I think there's a couple there for you, Anna.
Yeah. So just looking there at being kind of can change be made at any age? Absolutely. So one thing I always kind of come back to with people is it's never ever too late. We've supported people. My colleague Gemma's with me today. I think she was supporting someone who I think was 104 or something the other day. Yeah, so kind of we can make really positive changes. Obviously, it's about thinking through. If you're working with small children who've been sleeping in a destructive position for 5 years, it's going to take a little bit longer to support someone who's been sleeping in that position for 45 years, but absolutely never, ever too late, never too late. And just Anthony there, you've talked about funding from commissioning teams is difficult when it comes to sleep systems. They have been notoriously kind of challenging. There's something that if people don't understand them, they're easy to kind of, people know that everyone needs a wheelchair. People don't necessarily understand that people need a positioning system as well. So you're absolutely right that it needs addressing with NHS England because it's so hit and miss across the country. It's the epitome of postcode lottery. Some places that we know fund positioning systems, absolutely no problem at all. Some places it's a real challenge. We have a lot of resources we can share with, and we often speak to commissioning teams directly, and we'll do training with commissioning teams. Because again, if you have a commissioning team that aren't necessarily clinically kind of knowledgeable, they might not be clinicians themselves, so we're happy to come and do training sessions with people to help them to understand why they need to be funding these things. The thing also which they do tend to kind of listen to is the fact that if you provide a positioning system, then your care costs will become cheaper. If someone's body shape is more sort of conventional, everything becomes easier. It becomes much kind of more much cheaper to support them and things like that. So they do tend to listen to a bit of money, really. So it's a positioning system is one of those things where it's a you invest in it to reap the rewards kind of elsewhere. Postcode lottery in Scotland as well, absolutely Shona. Although Shona, excitingly with Scotland is the only place, the only country that has a national postural care strategy. So there is technically a kind of a national plan for therapeutic positioning. It's possibly not kind of understood or kind of implemented across the whole place, but I'm happy to support you. We do loads of work in Scotland, so would love to support you if you'd like to kind of know a bit more about it. Just a couple, the questions are flying in. A seating one about 90-degree flexion. Les,
What's the question, Kim?
What seating system would support someone with less than 90-degree knee flexion?
Less than 90 degrees. So we want a negative angle leg rest. So the chair is standard with a 25-degree negative angle. You can see that there. It may not come across very well on the screen. That's a standard across the chair range with a negative angle leg rest, but we have a service called Tailored Solutions. So where we have somebody with really acute contractures, the type of person who, if it were me being hoisted into this chair, my knee is kind of back at 45 degrees. We may need to get rid of the leg rest and manufacture a bespoke component to a chair to accommodate that person. We'd also look at the angle of the chamfer of the edge of the seat cushion as well, so we can accommodate that person. So there are solutions out there. Again, it does depend on the assessment process, but as standard, the chairs come with a negative angle, 25-degree leg rest. We've bespoke options to go further back than that as well.
Sorry, Anna.
Hey, that's okay. I was just making my way through the question. So where do we get bed positioning items from? So that would be from ourselves. So we can support you with regards to if you need any information on that. So I will send across again a link to like our website and things like that, and you can have a look at that. And Sarah Anderson, yes, we do provide training for care homes. It's something that we're really passionate about doing. So we can do that as well. And Shona, it sounds incredibly frustrating that you've got that strategy, but no actual funding aligned to it. Again, really happy to support you when it comes to kind of helping from a clinical justification point of view and things like that to help get things funded. Donna, if someone has a molded seat and a sleep system, would they benefit from a postural chair for therapeutic positioning as well? I personally think absolutely. We've worked with a lot of people who maybe have their positioning system for nighttime or for the lying posture. They'll then have their kind of wheelchair for getting out and about, and then they have an alternative seating solution as well, which provides kind of the sort of comfort and things like that. And I know that Careflex have got lots of different options from that perspective, haven't you guys?
Very, very much so. Quite often we work with clients who are in relatively complex, molded, bespoke wheelchair systems, but they need an alternative system for comfort, something different to sit out in, perhaps of an evening. It's funny, it's listening to some of the questions directed to Anna there. You know, it's very much a similar situation with funding for specialist seating. It is a little bit of a postcode lottery as well with that. It kind of flies below the radar. And just mentioning training, we're doing more and more. I think the awareness of postural care is growing. I think events such as this kind of spreads, sows a seed, and people go off and run with it. We also do lots of training sessions with care homes now, where staff want to become more engaged with postural care. They see the relevance of postural care for an individual who's been in bed for the last 6 or 7 months with a chest infection, becoming socially isolated. They see the relevance of specialist seating for that individual, not just in a health and well-being sense, not just in a clinical sitting out in a midline position, if that makes sense. I'm a non-clinician. You probably guessed that from my terminology.
I think you're very good, Les. Very good. You can, if I can understand what you're saying, then that's always good. Seating is like it's another world to me. I find it absolutely fascinating. I'm very good at the lying down stuff, but the seating stuff is not where I. It's not where
You do the lying down. I'll do the sitting down.
You do lying down really well. I'm good at that bit. So just very quickly here, just on, yes, we are sent recordings, aren't we, of the sessions today? Yeah, that is all happening. Any other questions at all from anybody?
All done.
Super.
Yeah.
I mean, if you need to access any of our services as well from Careflex, it's info. No, it's info at Careflex. Is that right, Kim? Info at careflex.co.uk.
Yep. Yep.
Yeah. And we have a network of specialist seating assessors and engineers covering the country. We've also a partner network as well. So, in a sense, you're only 20 minutes away from a Careflex chair. So.
So at the OT show.
That's a very good line, Les.
Yeah, come and see us at the OT show. What's the date, Kim? The OT show?
22nd to the 23rd of November at the NEC.
We'd love to see you. Come and see us. We'll have our chair range there. Yeah, we're also sponsoring one of the halls, Kim, are we?
One of the theatres.
Yeah, where Rebecca Dunstall, our clinical lead, is giving a talk on the 2 days. So we'd love to see you.
And I was saying we're not actually at the OT show, but we are about 20 minutes away from the OT show. So if people are visiting, then do drop us an email if you'd like to stop off for a cuppa, and if you wanted to catch up on anything else that we've talked about. We are about 20 minutes away from the OT show in Tamworth. So yeah, but thank you all so much for listening. I really appreciate it, and thank you very much for Careflex for organising it all. Thank you. Thank you. So if there's no further questions, it just remains for us to say so long and thank you for attending this afternoon, and we'll see you soon. Thank you. Bye-bye. Bye, everyone.